The skin is the largest organ of the body and is made of the epidermis, the dermis, and the hypodermis. Burns result from exposure of skin cells to an overwhelming amount of energy in the form of heat, causing cellular necrosis. The degree of injury depends on the temperature, the duration of exposure, and the baseline structural integrity of the skin, which means younger children and elderly individuals are at a higher risk of injury because their skin is relatively weaker. Okay, burns can be classified based on the cause, or by the depth of injury which corresponds to the severity of the burn. Burns are most commonly thermal, which can result from scalds, such as hot water, or flames, such as from house fires. Less commonly, burns can be electrical, like from exposure to lightning strike or high voltage electrical current, or from exposure to chemical substances, which can be acidic or alkaline. Based on depth, burns can be first, second, or third degree. First-degree burns are also called superficial burns and involve the epidermis only. A prime example would be a simple sunburn from a day at the beach, which appears red with no blisters. Second-degree burns are further subclassified into superficial partial thickness burns, which involve the epidermis and the superficial dermis, and deep partial thickness burns, which involve the epidermis and the deep dermis. Superficial partial thickness burns appear red and are often blistered, whereas deep partial thickness burns appear red or white with no blisters. Third-degree burns are full thickness burns, extending through and destroying the entire dermis. These appear leather-like with a charred appearance and tense feel. Usually, third-degree burns are surrounded by a rim of second-degree burns. Fourth-degree burns extend beyond the dermis, destroying fascia, muscle, or bone. Because third and fourth-degree burns destroy the entire skin, they destroy the skin nerve endings, and therefore can feel relatively painless. Due to their strength and velocity, electrical burns have an entrance and an exit wound, similar to a gunshot, but aside from that, the skin actually looks fine. However, internally, the muscles are injured, and even the heart can be severely damaged, so don't let normal skin fool you. Sadly, in children, specific burn patterns raise suspicions for physical abuse. These include burns with a sharply demarcated edge, smaller circular burns matching a cigarette tip, or burns in the perineal region matching a pattern that could only be explained if the child was dipped into scalding water. Management of burns begins at the scene. First, remove the individual from the source, making sure you don't expose yourself to electrical currents or chemicals. Additionally, remove all clothing, accessories, or jewelry from the individual, because these might be contributing to the injury. On the way to the hospital, cool the injured areas with room temperature water. It may be intuitive to use ice or iced water, but this should be avoided because it can worsen the injury. At the emergency department, management starts with the ABCs, that is, airway, breathing, and circulation. Using a fiber optic or direct laryngoscope, look for edema and obstruction of the airway. The decision to intubate is based on the presence of oropharyngeal swelling, stridor, and respiratory distress causing hypoxemia. But sometimes it's more subtle. Clinical signs like hoarseness of voice, facial burns, drooling, soot in the airway, or even singed nasal or facial hairs should encourage you to secure the airway prophylactically, even if the airway isn't swollen yet, or they're not in obvious respiratory distress. Sometimes it's too late and the airway has closed, and in that case, a surgical cricothyroidotomy is performed. In other words, if the main airway door is closed, you better break in through the window. Also, if exposure to carbon monoxide is a concern, like in the setting of a closed house fire, 100% oxygen is provided using a non-rebreather mask, and carboxyhemoglobin levels are measured. Alright, so burns cause a tremendous amount of fluid loss, but it's not as obvious as the fluid loss seen in diarrhea, vomiting, or bleeding. Burns increase capillary permeability, causing a tremendous amount of fluid to shift from the plasma to the interstitial space, which is called third spacing. To replace the loss, place 2 large-bore intravenous lines on an unburnt area of the skin. The amount of fluid to give depends on the total body surface area affected. Importantly, first-degree burns are not included in the calculation. To measure this, the rule of nines is used in adults. This method divides the body into 11 areas, each equal to 9%. The head is 9, each arm is 9, each leg is 18, that's 9 for the anterior aspect and 9 for the posterior aspect. The chest, abdomen, upper back, and lower back each represent 9%. 9 times 11 is 99, so that last 1% is the perineum. Sometimes the burn areas are patchy and it can be difficult to ascertain a percentage. To tackle this issue, the palm can be used to estimate, as the palm approximates 1% of a person's total body surface area. But because children have larger heads and smaller extremities, the rule of nines can't be applied to them. Instead, the more complex Lund and Browder chart is used, which takes into account the child's age. This chart can also be applied to adults. Alright, so once you've got the percentage, it's inserted into the Parkland formula, which calculates how much intravenous Ringer's lactate the individual should receive. Ringer's lactate is used because its composition is closest to the extracellular fluid. In the first 24 hours, the amount of Ringer's lactate to give in milliliters is equal to 4 multiplied by the weight in kilograms, multiplied by the percentage of the total body surface area involved. Half the number you get is given in the first 8 hours, and the other half is given over the next 16 hours. Alright, so the adequacy of fluid resuscitation is determined by inserting a Foley catheter and measuring the urine output hourly. In adults, 0.5 milliliters per kilogram per hour is considered adequate, whereas in children, 1 milliliter per kilogram per hour is adequate. The idea behind this strict fluid regimen is Jackson's burn model, which states that a burn injury is divided into 3 zones: a central zone of coagulation, which is dead and unsalvageable, a middle zone of stasis, and an outer zone of hyperemia. Adequate fluid resuscitation can potentially save the zones of stasis and hyperemia from irreversible injury. Under or over resuscitation can result in more tissue injury. Also, under resuscitation may cause acute kidney injury, while over resuscitation can worsen compartment syndrome or cause pulmonary edema. Tetanus toxoid should be given if the individual had not received it in the past 5 years. Also, tetanus immunoglobulin is added if they haven't received the primary series during childhood. In addition to fluid resuscitation, individuals with electrical burns should be placed on a continuous cardiac monitor because they might have cardiac arrhythmias. Electrical burns and burns that damage muscle tissue can cause rhabdomyolysis, which releases myoglobin into circulation. Myoglobin is toxic to the renal tubular epithelial cells, causing acute tubular necrosis. In addition to fluids, alkalization of the urine with the osmotic diuretic mannitol is recommended. Finally, extensive tissue necrosis releases potassium, causing hyperkalemia. Okay, now full-thickness burns appear as a leathery necrotic eschar. If that eschar circumferentially covers and pressures the neck, chest, or an extremity, it can impair perfusion, and this is called compartment syndrome. Also, an eschar around the neck can compress the trachea, and an eschar around the chest can impair breathing mechanics. To prevent tissue necrosis and hypoventilation, an escharotomy is performed. This involves making an incision through the eschar, relieving the pressure. Anesthesia is not usually needed because eschars are usually painless, since all the nerve endings in the dermis have been destroyed. A crucial aspect of burn management is analgesia. In minor burns, acetaminophen or non-steroidal anti-inflammatory drugs can be given. However, in more severe burns, IV opioids like morphine can help, especially if they're given early on. However, a challenging balance should be maintained because opioids can cause hypotension and respiratory depressions, side effects that we don't want in burns. Additionally, sedation with benzodiazepines or ketamine can be initiated to ease taking care of the wounds. Because burns increase the risk of stress peptic ulcers, or curling ulcers, intravenous proton pump inhibitors are given. The risk of venous thromboembolism, such as deep venous thrombosis or pulmonary embolism, is also increased in the setting of burns, and therefore, prophylaxis is instituted using unfractionated or low molecular weight heparin. Burns cause a hypermetabolic state, and individuals often can't feed themselves. Therefore, nutritional support is important. Enteral feeding using a nasogastric tube is preferred, but if they can't tolerate it, total parenteral nutrition, or TPN, is required. Next is local wound management. The skin is the most important barrier to infection, so if that barrier is damaged, the skin needs help preventing infection and augmenting healing. The wound should be cleaned with soap and water or sterile saline. Povidone iodine solutions, on the other hand, have been shown to delay wound healing and should be avoided. Acidic chemical burns should be irrigated continuously with water only for 20 to 30 minutes, and alkaline burns should be irrigated for hours, since they're far worse. It's actually not a good idea to neutralize an acid with a base, and vice versa. In fact, it's contraindicated, because this results in the release of thermic energy, which further damages the tissue. Okay, so any eschar or necrotic tissue should be debrided, because dead tissue serves as a habitable environment for bacteria. Debridement is done in a tangential method, meaning that thin layers of the necrotic tissue should be removed until there's uniform capillary bleeding throughout the wound. This indicates that you've reached viable tissue. An important aspect of preventing infection is giving antibiotics. But because blood flow is often compromised at the necrotic burn area, systemic antibiotics might not adequately reach it. Therefore, topical antibiotics are usually preferred, with a large number of options to choose from. Silver sulfadiazine covers most gram-positive and gram-negative bacterial organisms, as well as fungi, and its application is not painful. Its downside, however, is that it doesn't cover Pseudomonas aeruginosa, which is the most common cause of sepsis from burns, and it's not conducive to wound healing. Mafenide acetate covers Pseudomonas, but it's painful to apply. Silver nitrate is a good option for individuals with sulfa allergies, who cannot be given silver sulfadiazine. However, it leaves a blackish stain, making it difficult to assess the wound. If a wound infection is suspected, a tissue biopsy is obtained, and topical as well as systemic antibiotics are tailored to the offending organism. Sterile dressing should be applied daily, which help in wound healing. Alright, as a quick recap, burns can be categorized by cause and include thermal, chemical, and electrical burns, or by depth and include first, second, third, and fourth degree burns. Evaluation begins at the scene. Management also begins at the scene and includes removing the individual from the source and applying room temperature water to the affected areas. Analgesia should be initiated as soon as possible. In the emergency department, evaluation begins with the ABCs: airway, breathing, and circulation. Early endotracheal intubation is indicated if the individual has any of oral pharyngeal swelling, stridor, respiratory distress causing hypoxemia, hoarseness of the voice, facial burns, drooling, soot in the airway, or singed nasal or facial hairs. When carbon monoxide poisoning is a concern, 100% oxygen is provided, and carboxyhemoglobin levels are measured. 2 large-bore intravenous lines are inserted to initiate intravenous Ringer's lactate. Using the rule of nines, or the Lund-Browder chart, estimate the total body surface area affected, and insert it into the Parkland's formula to determine the amount of fluid in milliliters to give in the first 24 hours. This is equal to 4 multiplied by the weight in kilograms multiplied by the total body surface area. Half is given in the first 8 hours, and the other half is given in the next 16 hours. Urine output should be monitored to make sure you're not over or under resuscitating the individual. Additional therapeutic measures include providing analgesia, the tetanus toxoid vaccine, initiating stress ulcer and venous thromboembolism prophylaxis, and inserting a nasogastric tube for enteral feeding. If the necrotic eschar is causing compartment syndrome, an escharectomy is performed. Burn wounds are cleaned, irrigated, and thoroughly debrided. Topical antibiotics are often indicated to prevent infection, and options include silver sulfadiazine, mafenide acetate, silver nitrate, and many more.